Okay then, ladies and gentlemen. All right, I hope anybody's had a comfort break that needed one. In our last session, we were hearing about reputation management and serious incidents. And now we're going on to something that, 3 words that I know from experience, can strike the heart, fear into the heart of anybody in social care. We're going to talk about serious case reviews. But we're going to talk about them from 2 people. Vic Citarella, who's the director of CPEA, which for some reason I can never say, and Margaret Flynn, who is chair of Lancashire County Council Safeguarding Adults Board and also senior associate with CPEA. And they both have a great deal of experience of serious case reviews and on learning from them and acting on the findings, which I think is the key message. Thank you very much.
Thank you. Good afternoon, everybody. Can you hear me if I stand here? Hi, Yanti. We've got about 10 slides for you, and in those 10 slides, we're going to try and give you some of the flavour of over a year's work in undertaking a serious case review related to Winterbourne View Hospital. Inevitably, we will only touch a small element of the things that we would like to cover. But these are the headings of the slides, and Margaret is going to do the bulk of the talking, because Margaret did bulk of the work, but we did do the project together, when we were invited by South Gloucestershire Council to undertake this rather different and complex serious case review. So we're going to take you through some thinking around safeguarding, some thinking about learning about safeguarding, a look at the assessment and treatment for people with learning disability and autism, and then on into talking about commissioning and quality assurance. I'm going to do a bit of talking about leadership and management in about 10 minutes, quarter of an hour, and then Margaret's going to wind up the presentation with these last 3 points here around patients and families, some thinking about serious case reviews themselves, and then we'll leave you, just in case people don't ask questions, with some questions for you to take away. These are questions we've developed over the last year, really, in doing workshops like this and in roundtable events and a range of different things that we've been asked to do. So on that note, over to you, Margaret.
Thanks, Vic. We start from an interesting sort of premise, and that's really that this is not a neutral subject, and the topic of adult protection or safeguarding is something that we all know something about. And some of us have not been blessed with early childhoods in which we were cherished, for example. So we all bring something to this very complicated subject, and sometimes that can be less than helpful. So it's not a neutral subject, and it's also an incredibly untidy subject. So those of you who have read policies, for example, around adult safeguarding, you'll believe that it's very neat. You know, we know what financial abuse looks like, we know what sexual abuse looks like, and physical abuse. Life isn't like that, and in fact the most typical form of abuse is actually multiple abuse. So that if I intend to rip you off, I start off being nice to you, and at the end of it you will feel completely betrayed, and it will have got to you. We know, for example, that our policies do not accommodate some of the very perplexing subjects that adult safeguarding, adult protection has to address, including, for example, the subjects of self-neglect, boiler room fraudsters. We've had a lot of people in Lancashire who have lost, for example, their homes because they've gone on the internet and they've believed that they were buying something that turned out not to be real. And we also know that we don't have any sense of the true scale of adult protection or the number of occasions when people are abused in some way. And that's not least of all because it's humiliating to put your hand up and say, that's happened to me. There's a lot of fictions, unfortunately, in this very complicated subject. For example, we know exactly how many people have been abused. We don't. There is a belief somewhere in some quarters that actually if you just get rid of the people who are responsible, then your service is fine. And we also have some incredibly impressive QA systems. They do not in themselves keep people safe. Other people keep people safe. I think we're going to give a particular slant to Winterbourne View Hospital this afternoon, but we know that adult safeguarding addresses not simply the random acts, the lashing out, but also the prolonged and sadistic violence. And I was interested to hear the former speaker talked about the media. The media can indeed hold up a distorting mirror when things go very badly wrong in services. And in our experience of serious case reviews, they almost immediately go to the director of adult social care and ask if their head is going to roll. And we know too that when institutions have been found guilty of failures or have been exposed, that they promise reform. No one in their right mind would do otherwise. They typically say, we will learn the lessons. And that's often the launch pad for the commissioning of a serious case review. There are bystanders, there are good Samaritans in every service. And what was very clear to us was that there were people within knowing sight of what was happening to patients at this hospital. A serious case review clearly does not bring to a close any learning. We're very clear that if there had not been an undercover reporter over 2 years ago working at this hospital, it's unlikely that the events would have come to light, if at all. And we know that the exposure of this hospital has emptied of meaning any notions that we have of hospitals being places of healing. We know too that we have not identified all the crimes that were committed at this hospital, not least of all because the patients continue to disclose things that happened to them for the period that they were in the hospital, but they were so traumatised by the experience that they were not able to communicate it all to the police. And I think what's particularly punishing for families to know is that the company that owned Winterbourne View Hospital, Castlebeck Care Teesside Limited, was not starved of funds. And they would not disclose how much was spent on patient treatment. The average weekly fee was £3,500, and we know that for at least one patient, it was a shade under £10,000 per week. They acknowledged that from a financial perspective, it was one of the best performers. And we also learned that business opportunism of the form that shaped Castlebeck, shaped Winterbourne View Hospital, does not have to comply with government policy. For those of you who are interested in valuing people now and the strategy for people with autism, you'll find nothing in any of those strategies that say we need assessment and treatment units and we need them to grow at the rate that they've been growing since 2000. There are lots of fictions to be challenged, and we came across most of those fictions as we were preparing this work, and that one of which is that hospitals for adults with learning disabilities and autism solve problems. Conspicuously, they do not. You do not fracture people's relationships with their families, with their GPs, send them 200 miles up the road and cross your fingers. Good things do not arise from that. We know too that the disciplines of learning disability nursing and psychiatry are really not equal to providing mental health or physical health treatment to patients in some of these institutions. It was really, I think, probably a shocking moment for us during the serious case review was to discover the medical records of a patient, a male patient, who had disclosed to a member of staff that he'd found a testicular lump. And we could find no subsequent reference to actions arising from this discovery. And there's something truly bizarro about a serious case review getting in touch, or rather review writers, getting in touch with the director of social care, this was a hospital of course, and saying wherever this man is now, he needs to be followed up by a GP and he needs to be seen urgently. He was, and he did receive treatment. But it's astonishing that this hospital could not even attend to something as urgent as that. And we know that institutional care is with us yet. And I suppose a question that we asked is, if the signs of abuse were there at Winterbourne View Hospital, how do we pick them up? And who do we believe should pick these signs up? I've been interested in the response of some of the NHS commissioners who were disbelieving that what they had written into contracts was not being delivered. And it is truly naive to believe that I've written it down, so it's going to happen. Nobody remained in touch with these patients, irrespective of the sums of money that were being paid for them. The commissioners truly did not know what it was that they were purchasing. NHS commissioning was really little more than finding placements for people, typically on a Friday afternoon, when a family were in crisis. We know too that the decisions about contract renewals for these patients were not based on hard data. So nobody was asking the question of the hospital and the staff working at the hospital, what is it that you're reliably doing consistently, and how are you turning this person's life around? Those questions weren't asked. The cheques continued to be signed. We also learned that although this hospital had a fairly elaborate system of clinical governance and elaborate QA systems, they do not keep people safe. And I would advise you to be very cautious of any QA material that is laminated and embossed. You should be cynical when you see such material. Providers are not disciplined by the market, and hospital employees are not consistently brought up short by the recognition of shared humanity. And that has been particularly hard for the families in the wake of the scandal to deal with. How could they witness some of these things happening to our relatives?
Thanks. Just pause for a minute. People saw the Panorama programme, didn't they? Yes? Lots of nods around the room. Just think back to the bit of the programme that sits in your mind. Just let it come to the forefront of your mind. For me, the thing that sits in my mind is not necessarily the thing that sits in other people's minds, the scenes of violence and the things, the horrific scenes. One scene that particularly sits in my mind was a shot of a manager in the background watching this happen. There was a particular scene in the original Panorama programme where there's some people looking down the corridor, and it transpires that the two people looking down the corridor were managerial grade nurses. And I just want to say a few words about leadership. Perhaps not quite as cynical as Margaret has become latterly, because I'm not wholly convinced that the private sector is incapable of leading a service. But I was taken by this particular quote here at the top: "Profit without purpose is a recipe for disaster." And this is a quote from none other than Elizabeth Murdoch. She made this in a Guardian media speech. And I think this really was one of the touchstones that we shaped the serious case review around, this notion of statement of purpose. A registered service has a statement of purpose. This particular registered hospital's purpose was assessment and treatment, yet you could find no assessment and treatment actually taking place. So not only was it set up for a purpose that was questionable, it wasn't actually pursuing that purpose anyway. So it isn't surprising that actually the leadership bit was found wanting. And we did for a while think around the idea that it was a void in leadership was a problem. But actually, there's always leadership going on, and it's where it comes from and where it's located. And in the case of Winterbourne View Hospital, it was a support worker-led form of leadership of a particular type, led by particular individuals in a particular way. That led to the abusive scenes that you all brought to the forefront of your mind just a minute ago. It could have been actually a staff room culture that was positive. Bottom-up leadership does not have to be necessarily a bad thing by definition. But we cast our minds to the book The Lord of the Flies in thinking about this, that when you take away the infrastructure of management and leadership and life and coordination, even in a scene of paradise such as in Lord of the Flies, you can get savagery as a result, but you could also get harmony, utopia and bliss, I would like to think. Anyway, what we did concur with was the notion that another well-known leadership quote, culture eats strategy for breakfast, that we actually, this was the case at Winterbourne View Hospital, that they did have lots of plans, lots of documents, lots of strategies, lots of glossy embossed QA documents, but actually the culture wasn't conducive to those strategies actually being of any use, i.e. they were, to use another quote, casting their seeds on stony ground. In the review, as a consequence, we stressed the role of the registered manager. We were somewhat taken aback by the lack of focus on the top person, as it were, that there wasn't one, in fact, for 18 months, Margaret? 2 years, 18 months, and when there was one, they were located in Darlington, 200 miles away. And that's just is astounding if this person is supposed to be the lead professional, is supposed to be the protector and the champion of the patients. And we were just startled. If you were looking to get a service for your relative, or you were looking for a school for your children, you'd go and talk to the head, wouldn't you? You'd go and talk to the officer in charge of the care home. And the same should apply in a place like Winterbourne View Hospital. And one of the, in concluding comments on leadership, one of the other things we built into the recommendations and are still pursuing in following up with the Improvement Board and with government is the issue of corporate governance. The question of the responsible individual, the registered owner of the service and their particular responsibilities. And we comment that this is an ill-defined role. Certainly when we started, the view of the regulator was that this is just an administrative function, and we would like to see it as being one around direction and strategy, around quality, and around ensuring that leadership and supervision of the professionals in the service actually takes place. And we would commend to you a document recently published called Leadership Starts With Me, which is a social care publication, but these particular bits of work are done in working together with leadership academies across social care, across the NHS, and with children's services. So some of the leadership thinking is being coordinated across the 3 leadership academies. So I'll conclude there, Margaret, and if you could wind up with some families, that would be really good.
Thank you. These are not the words of families. If the report is available on the website, but it seemed to us helpful to really summarise what it was that families in the wake of the scandal at Winterbourne View Hospital wanted. We were able to interview around 12 families. There had been in total 51 patients who had been at Winterbourne View Hospital since it opened in late 2006. So not very many. Although we hear a great deal about patient-centred support and about person-centred support, and you wouldn't be surprised to know that everybody at this hospital had a person-centred plan, families talked about the importance of a relationship, having a relationship with someone with whom they could discuss the progress or concerns that they had about their relative. And that was not there, either in their localities or indeed at Winterbourne View Hospital. And without that, they could not have any faith in services. They very much wanted empathic and mature staff who were sensitive to the subjective experiences of their daughters and sons. Families talked, and some of the patients themselves talked about how difficult it is to be different and to feel different. And for all of us at some stage in our lives have felt different. And you will recall what it's like to yearn to be like everybody else. There are no tablets that you can take for this, but so very many of these men and women who were patients at this hospital acted out some of the frustration of being different. And that, for me, was exemplified by one particular man who had secured employment. His family were incredibly proud of him. This was a young man who was doing really very well, but he was promoted at work, and the promotion required him to do other tasks. Most of us would ask, could you show me what to do? But he wasn't able to do that. And one day he exploded at work, and they were so appalled that they said, that's it, go, you may not return. And as a result of that, he became very, very depressed. And his family sought assistance from the local authority, and they were offered respite care. And they said, he's never been away from home before. That doesn't make sense. And it really was only when this young man attempted to take his life that he was ultimately placed at Winterbourne View Hospital. And I think what is really very significant about that man's circumstances is that his behaviour at the hospital began to replicate that which he had witnessed and that which was done to him. He sadly is one of the patients who has not yet returned to his family or to his community. He burned the clothes that he wore at Winterbourne View Hospital, and he has begun to urinate in cups. Those of you who witnessed some of the scenes in the Panorama programme will recall that some of the most egregious offences occurred in people's bathrooms and toilets, where we expose the most vulnerable parts of our bodies and where we should be most safe. And to consider Tom's behaviour, it is very sensible, is it not, to urinate in a cup with your back to the wall so that you can actually see who's coming towards you. Challenging behaviour is communication, and it was never regarded as such at this hospital. Families acknowledge too that there are emotional demands in working with people with troubled histories, and they talked about being terrified of some of the appearance of staff. I know that it can be fashionable to have tattoos and all sorts of chains in bits of your face, but families were terrified that staff looked scary. And those are the people who are working with their daughters and sons. They wanted staff to have good role models and effective managers, and they also wanted to have their perspective and experience acknowledged. They could not believe that NHS commissioners had no understanding of what it was that they were buying, or indeed that they never visited the service. That responsibility was delegated to very junior people and should not have been so. And they very much wanted the money for hospitals to be transferred to their communities. I would urge you to think carefully about these, because I do think it's incredibly hopeful in terms of working with and alongside people who are otherwise perplexing. Next one. Yep. And I suppose one of the things that we reflect on about serious case reviews, usually they're markers. There are points of reference. So, for example, people say, well, before Winterbourne, after Winterbourne, or in our locality in Lancashire, when we had a serious case review, then after we had that serious case review. At their best, they are a multi-agency view from a distance, and they have a very specified time frame. They can be a way of learning about shortcomings, most particularly about interagency arrangements and communication. I get a bit twitchy when people say they all say the same things. You know, they all say we've got to communicate. That's not good enough. I don't believe they all say the same thing. What we have to do as writers of reviews is edit usually an enormous amount of written material and offer some sort of explanatory framework. And we have to champion multiple perspectives and promote interprofessional conversations. But probably very challenging is to be fair, to be as fair as we can be. I think Vic has slightly misrepresented my view about the private sector. I don't take the view that the private sector is all bad, but I was extremely concerned that this government can promote think personal and act local, and we've got private equity owners, funders in Switzerland, funded via Jersey, pumping money into a hospital that leaves it permanently in deficit. That's my problem with that. They are a way of holding people to account and agencies to account, but not individuals to blame, and that can be really very hard for families to understand when their relatives have been hurt or harmed. And it was interesting that there were a lot of parallel reviews related to Winterbourne View Hospital, and it's fantastic that there is now a concordat with a programme of activity that's being acted upon. But it was a challenge for us that it was one of many reviews, and it would have been helpful for there to have been a coordinating or an individual to have a coordinating role, because the police investigation necessarily had to take some considerable priority. And
okay, that's about it in terms of the presentation. This slide here we left on the presentation because this is a slide that we use when we're doing working groups around in a different sort of format. So we thought, we'll leave it here because it just might help prompt some questions from you. So thank you.
Thank you very much. Can't hear you.
Right there. Do we have some questions, please? No, John's got one, but I'm going to go to the lady at the back first. Can you wave your hand again so that the microphone can get to you? Thank you very much.
Hello, I'm Sarah Shackle from Bath and North East Somerset. I'm a commissioner in social care. I'm just wondering, it's a subject that no one really ever talks about, but do you think that there's any learning that we can glean from perpetrators of abuse? And if so, how might we go about doing that?
Yes, indeed. I think there is learning from the perpetrators of abuse, and I'm very encouraged by some of the first-person accounts that have been gleaned by organisations such as Peer Professional in making it possible, for example, for adults with learning disability and some adults with mental health problems to talk about what it was that was the backdrop to their own abusive behaviour. I think it's much more difficult and challenging when we're not talking about vulnerable adults responsible for assaulting others. It's an uncomfortable subject, and I think for agencies responsible for the employment of people who are responsible for criminal behaviour, the desire is really to get rid of those individuals as soon as legitimately possible. I do know from some of the interviews that the police have undertaken at Winterbourne View that staff there spoke of never being supervised, ever, never being told what was correct behaviour. And I think that is really very significant. I think it simply endorses all that Vic has said, that we desperately need effective managers and people who do not hesitate to intervene so that behaviour does not, over time, become institutionalised. But we do not have very compelling first-person accounts of the experience of perpetrators.
I think can I just add a little? I think it's probably, just going back to the previous presentation and making that link, I think the owners of Winterbourne View Hospital, perhaps they started off with quite an open perspective, but it became a fairly closed agenda quite quickly for whatever reason. Maybe they're insurers, maybe they're shareholders, I don't know. But it would have been very useful to interview some of the hands-on support worker staff, or to have had the perspective of managers. But a lot of that material was actually heavily redacted or not provided to the serious case review. We still have it on our agenda, if we can organise it with the BBC, to get feedback from the undercover reporter themselves. Whilst they weren't a perpetrator, they were there and they would have gone through induction training, they were recruited, and it would be useful to get that bit of wisdom from the undercover reporter, looking back on the experience. Thank you.
Now we have another question at the front here. As is always the case, the microphone is always at the furthest point. Hang on a moment, just so everybody else can hear you now.
Well, Winterbourne View was discovered by the use of the camera, and that's also true of Ash Court, and it was of the Oakwood in Leeds. In each case there was a camera. Would you support a much wider use of cameras, even standard use of cameras, which perpetrators of these kind of things would worry about a little before they did the things they do?
I think I made the observation that some of the most egregious assaults occurred in people's bathrooms and toilets. Would we really want cameras in our bathrooms and toilets? We would indeed. I think it's an interesting question. I think, however, these staff knew where to go. There was a quiet room, a small sitting room, and patients were assaulted usually out of the main areas within the hospital. Think about speed cameras. We know they're coming up, and we behave. There is concern about the prophylactic use of cameras, and there's some interesting documentation around that, particularly with the mental health service users. They're extremely concerned about the prospect of this. But I think with social media, we know that an image is much more compelling than a report. I think I don't think we're that far away from families now starting to take photographs of their relatives, particularly if their relatives have been harmed, of bruises, and going to the media. And I think we should be ready for this.
I think so. It's a good debate for the sector to have, and I think it's overdue. In that, I think we're arriving at a stage where all our actions are on camera, whether we know it or not, or recorded in some shape or form. And we've certainly, I'm looking at Yanti nodding, he I know has dealt with a disciplinary issue where somebody was recording with a camera under the bed, and it's those sorts of things, and we need to think through a strategy around this sort of thing, an approach to this to technology. Certainly the police at Winterbourne View took the view that they would have put cameras in a lot earlier, given the opportunity.
Yeah.
Thank you very much. Looking at the time, I now have to draw this to a close. I was looking at the very interesting slide, though, and so I'll remind you, all these presentations will be available for download, and it may well be very useful to track down this slide and have another look at it. We now take a break. Officially for you to look around the show, unofficially to go and grab a coffee. We'll be back in these sessions in half an hour. And can I ask you to take the opportunity to fill in those valuable feedback forms if you haven't done it already. Thank you very much.
Thank you. Thank you.